materials within the mesangial matrix. It can be highlighted by the use of BAS stain. Glomerulosclerosis might be diffuse rather than nodular pattern. In case of diffuse glomerulonephritis, the bed membrane will be thickened throughout the glomerular tuft with widespread expansion of the mesangial matrix. It has the same mechanism and pathogenesis of Kieman-Steele-Wilson nodule or nodular glomerulosclerosis, but the extent of involvement is more wide. If renal disease left untreated, it will end by end-stage renal disease, which is characterized by high blood urea nitrogen level and serum creatinine levels. Usually it occurs after the patient has lost more than 75% of the glomerular filtration rate. And the treatment in this case is dependent mainly on hemodialysis or renal transplant. Microscopic examination of kidneys with end-stage renal disease will reveal widespread glomerulosclerosis. These are sclerosed glomeruli with tubular thyroidization, which means that the appearance of renal tubule will be similar to thyroid follicles due to flattening of the lining epithelium and deposition of eosinophilic material within the lumen, like the accumulation of colloid within thyroid follicles. Also, there is chronic inflammatory infiltrate within the interstitium along with fibrosis and thick-walled blood vessels. As you know, the most common cancer of gallbladder, of urinary bladder is urothelial carcinoma. Urothelial carcinoma grossly usually appear as a fungating, polypoid, or papillary lesion attached to the mucosa of the urinary bladder. It might reach large size and fill the entire bladder lumen. Usually it is present by hematuria, either microscopic or gross hematuria. It can be seen by cystoscopy, and after biopsy examination, diagnosis might be confirmed of urothelial carcinoma. This is another example of papillary urothelial carcinoma filling the entire lumen of urinary bladder. As you know, urothelial carcinoma is associated with smoking. Urothelial carcinoma might present along the urinary tract, starting from the calyces, renal calyces, and down to the urethra. This area of wide thickening of the renal calyceal system represent urothelial carcinoma with extension into the renal pelvis. Another example of invasive urothelial carcinoma, which occupy the entire renal pelvis, leading to obstruction of the flow of urine from the pelvic calyceal system and massive dilatation of calyces with formation of secondary hypertension. Also, you can see here the tumor infiltrating into the renal parenchyma. Microscopic examination will represent these long papillae. They are formed of central fibrovascular cores supporting multiple layers of malignant urothelial cells. Usually it has multiple layers with increased thickness of urothelium lining. The malignant cells will lose their normal polarity and appear irregular and haphazardly arranged. Cells with hyperchromatic and pleomorphic nuclei also are present, along with scattered or widespread mitotic figures. As any other type of carcinomas, urothelial carcinoma can be in situ. As you know, carcinoma in situ is a type of malignant tumor which are confined to the basement membrane. As you see here, the malignant or the anaplastic features are involving the entire thickness of the urothelium with these large hyperchromatic and pleomorphic nuclei. There's also mitotic figures scattered in between, but they are respecting the basement membrane and there is no invasion or extension into the underlying fibrovascular stroma. So this is an example of urothelial carcinoma in situ. The most common tumor affecting or malignant tumor affecting the kidney is the renal cell carcinoma. Renal cell carcinoma usually arise in one pool of the kidney, either upper or lower pool. It is a well circumscribed tumor. It has a yellow cut surface due to high lipid content within the malignant cells. Also, it grows in a nodular fashion with foci of hemorrhage and cystic degeneration. Another example of renal cell carcinoma, which reaches a large size, it is here up to 15 centimeters. Renal cell carcinoma can grow into a large size because it is a retroperitoneal organ, and it has a space to grow into a large size without giving any specific symptoms. Another example of renal cell carcinoma, which appear here as a multilocular cyst filled by serosanguinous or hemorrhagic fluid. The malignant infiltrate may infiltrate through the perinephric fat, which is the fat surrounding the kidney, or into the renal vein. Also, it might infiltrate into the associated or adjacent adrenal gland. Any infiltration outside the renal capsule will upstage the tumor, especially the involvement of renal vein and inferior vena cava. Involvement or obstruction of the renal vein and inferior vena cava will lead to obstruction of the adrenal vein, and as a consequence, the adrenal gland will appear hemorrhagic. في شيء؟ مش فاهمين شيء؟ عندك سؤال؟ اتكلم بصوت على الأقل، يعني صوت ما نسمعش. على الأقل مثلا لو مصرين إنك تتكلم. Microscopic examination shows that the malignant cells grow in a nested or nodular pattern with delicate fibrovascular stroma in between. The malignant cells are large with abundant clear cytoplasm and well-defined cell borders. Nuclei are usually rounded or oval and centrally located, and nucleoli may be seen in high-grade tumors. Another example of renal tumors, which is a childhood tumor, is Wilms tumor. Wilms tumor usually grossly appear as a lobulated white mass. This tumor here is seen representing or replacing the entire renal parenchyma. Only a small rim of normal parenchyma is remained. Usually, Wilms tumor associated with genetic defect in chromosome 11 and presented by abdominal distension. Microscopic examination will show that the tumor cells grow in nests and sheets. These are nests, and this part represents diffuse growth. Separated by fibrous tissue septa, it might be separated from the adjacent renal parenchyma by fibrous bands. On high power, the malignant cells appears or the nuclei appear large and hyperchromatic with little cytoplasm. Some show diffuse growth pattern like in this area, and some are arranged into poorly formed tubules which resemble the primitive glomerular and tubular structures. Any questions? Thank you.